Okay. Bismillah, alhamdulillah, salatu wassalamu ala rasulillah. Welcome everybody for this seminar, which is the first seminar actually and webinar which is being conducted in collaboration with the Irish College, supported and sponsored by the Saudi Commission for Health Specialties. I would like to thank actually Dr. Sulaiman Al-Umran for his support to make this webinar come true, and I would like to also thank Dr. Ayman Abdu for his tremendous and huge support for this initiative and this project. Today we have a distinguished guest, Dr. Quinlan from Ireland. Dr. Quinlan is really an ideal family physician or general practitioner. He has a very well rounded experience in different countries, Ireland, UK, Australia, and he had multiple qualifications the field of general practice or family medicine, dermatology, and he also completed a master's degree in medical law. Happened to be in the same school where I completed mine too, so I have a special connection with Dr. Quinlan today. So thank you all for joining us today, and a special thank to Dr. Quinlan for accepting the invitation, and the floor is yours, Dr. Quinlan.
We'll also in this webinar look at the pharmacological management of type 2 diabetes, again looking at the role of audit and patient safety at all times. So overall, what I would like is that we would enhance our ability and confidence in our diagnosis and management of uncomplicated type 2 diabetes. Just before we start, the principle of therapeutic inertia, and therapeutic inertia is where we delay in making the necessary changes. And what I'd like to think is that if we find our patients' results aren't improving, be they lipids, be they weight, be they HbA1c, the blood pressure, if they're not improving within 3 to 6 months, then we would firstly assess compliance with therapies, which is often an issue, and secondly, intensify the treatment, be it pharmacological or lifestyle measures. So at all times, we should keep at the back of our mind that therapeutic inertia is to be avoided. So should we be screening for patients with diabetes, or is it active case finding? And is this just a matter of words? The World Health Organization has a very clear definition of screening using the Younger-Wilson criteria, and it's not accepted that we should be a formal screening process for type 2 diabetes. However, active case finding is a less rigorous process where we actively target resources to try and identify high-risk people at risk of an illness. And what I would look at is we go hunting for people who are likely to have diabetes rather than waiting for them to present with symptoms or signs. And certainly I found as I got involved in diabetes that originally when I would have diagnosed people with type 2 diabetes, they would have presented with symptoms of it. But as we became more aware of the symptoms of diabetes, we would go looking for it. And it's become much easier now that we can use, since 2011, that the World Health Organization have said we can use HbA1c to diagnose diabetes. It's become much easier to find people with diabetes. So we probably should use active case finding. And as I would say, we should go hunting for these people, because unfortunately, many people with type 2 diabetes are diagnosed with a complication, which means they've had it for many years and without diagnosis. And case finding is more justifiable when the evidence for a formal screening program isn't available, and for diabetes, it's not yet available. So in terms of case finding, all of these really, and these the various guidelines. And what I was going to do is, if you imagine a patient of yours, and I would say if you pick a fictitious maybe 35 or 40-year-old person and think, well, should we be testing them? And the various guidelines, the Canadian guidelines and Australians say everyone over 40 years, the ADA guidelines say 45, and the variants say every 1 to 3 years. So if we take the sort of most soft guideline would be everyone age 45 and over every 3 years. And that might be okay if we have a slender adult who goes running marathons and is really fit. But equally, if we had a sedentary obese person who maybe had both parents with type 2 diabetes and might have siblings with type 2 diabetes, then it might be more appropriate to check them at the age of 40 or even earlier, and possibly every 1 year. So, you know, I think we need to look at these flexibly and taper all of this to our own patients. Clearly, we should, anybody who has had pre-diabetes, which again is a HbA1c in the pre-diabetes range, and I'll come back to that later, and gestational diabetes, we should check these probably every year. And again, adults who are overweight or obese with additional risk factors, and the additional risk factors I've listed below here. So people with a sedentary lifestyle who have relatives with type 2 diabetes, hypertension, dyslipidemia, known cardiovascular disease, a history of gestational diabetes, or maybe women having a big baby, 4 kilos, 4.5 kilos or over, and certain high-risk ethnic groups. And these vary around the world, but we all know who they are. So when we look at this, really, it is an awful lot of our adult population. And if we start actively case finding, we will find these people. And certainly that was the case in my practice many years ago. When we went looking for them, we actually found them, and we kept finding people with diabetes for many years. So the accurate diagnosis of type 2 diabetes changed in 2011 when the World Health Organization brought in the use of HbA1c. Prior to that, really, it was based on the person with symptoms and a fasting glucose of greater than or equal to 7, or a random glucose of greater than or equal to 11.1. I certainly find these figures difficult to remember in my head, and I'm doing this all the time. So I tend to keep them written down, but that's symptoms. And as I said, really, ideally, we'd be trying to diagnose people before they have symptoms. So an easier way is with the HbA1c of greater than or equal to 48, being aware of some conditions which can help us to misdiagnose it. But these are not common for most of our everyday practice, and certainly we should be aware of it. We all are aware that some patients, if we only use HbA1c as the form of diagnosis, you know, one of the criticisms of that is that we will miss some people, or we may have a delayed diagnosis of these people with type 2 diabetes. However, if we are checking people reasonably regularly, so if we take my fictitious patient and I've checked him when he's 35 and maybe 38 and 41 and 44 years of age, and I find his HbA1c started in the maybe mid-30s and gradually crept up, then actually once he's in the pre-diabetic range, I'm managing his risk factors. So HbA1c is a convenient way of diagnosing diabetes, and patients don't have to be fasting when we do it. So that's a real benefit for patients and for physicians. We can also, as you know, use an oral glucose tolerance test, and they're the figures for this. Again, patients don't like doing oral glucose tolerance tests. They're time consuming. Drinking 75 grams of glucose isn't particularly nice for patients. So increasingly, people are using HbA1c as a convenient, easy method of diagnosing diabetes for patients. If it is abnormal in the absence of symptoms, we should repeat the test on a different day to confirm the diagnosis, and that helps ensure there wasn't a laboratory error contributing to a diagnosis. So ideally, it would be 2 tests on different days. Once we have diagnosed someone with diabetes, it's a great idea to code them and register them. And the advantage of this is that firstly, it helps us to access our patients with diabetes, and we can register them with our health service. We can then recall these patients readily, and we can undertake a clinical review. And again, I'm just going to outline when I talk about uncomplicated diabetes, what we mean by uncomplicated diabetes. And essentially, it's people with a HbA1c of less than about 58, although, you know, you can be a bit flexible on that. These are people who are controlled on diet, although these are relatively few, and on 1 or 2 glucose lowering medicines, not including insulin. Insulin is a different kettle of fish entirely. And these are patients who haven't yet had any complications. And a lot of the complications don't happen in the first 7 to 10 years when people have diabetes, especially if it's well managed. The common complications we mentioned earlier are eye disease, neuropathy, and active foot disease. We'll touch on these. These patients would have a reasonable renal function. Their creatinine is okay. The eGFR is over 60, and that's a good index of their renal function. It roughly approximates to their renal function, and these are patients who are aware if they get hypos. And most of our patients that we see every day will fit into this category. So going to the initial management of these patients with uncomplicated type 2 diabetes, really, I divide it into two main aspects. There's the lifestyle issues, which are really important, and then there's the drug management of these patients, the pharmacological therapies. So the lifestyle issues, and we're all familiar with this, is really weight loss. And when I have my patients with uncomplicated or newly diagnosed, so I have one of my patients with newly diagnosed diabetes, the two main things I talk to them about really are weight loss. And I would encourage them, most of the health benefits happen with losing between 5 and 10% weight. And often, certainly my patients will say, well, what's my ideal weight? But we're not trying to get them back to their ideal weight. Most of the health benefit lies in losing between 5 and 10% of a person's weight. So if you've a man or a woman who's 100 kilos, that's losing somewhere between 5 and 10 kilos, which I think is a relatively modest and achievable ask for most of our patients. We'll come back to that weight loss in a moment and some new evidence on it, whether we should be looking for more. It's very helpful for our patients if we can support this weight loss with a dietitian, and we'll touch on that in a minute. So weight loss is one really important aspect. The second very important aspect, exercise, and they should be doing at least 150 minutes a week, which should ideally be both aerobic and anaerobic. Obviously, it's really important with all our patients, and not solely those with diabetes, that we address their smoking status. And in terms of doing an audit, it's worth looking at, have we actually documented that we have given this advice, that we have the smoking status and the cessation recommendations actually documented. So looking at the lifestyle diet and the role of the dietitian in a little more, ideally all patients with type 2 diabetes would see a dietitian if that resource is available, and in many areas it's not, and equally if it is available, it's a fantastic opportunity. I would consider our dietitians provide a really valuable resource. They also help patients not alone provide them with factual information, but also about strategies for behavior change. And really, that's a really important role for the dietitians. If the resource is available, an annual dietetic review and a structured diabetes education program, all are available for our patients. Then just look ahead a little, maybe look into the horizon and what might be coming down the line. And is weight loss the cure? There was a really interesting study in the UK, in Scotland and in the north of England, where they looked at patients who had lost over 15 kilos of weight. And what they found was that of those who had lost more than 15 kilos, nearly half of them, their diabetes, type 2 diabetes, went into remission. These were patients with recent onset diabetes of less than 6 years, where of those who hadn't that very substantial weight loss, only 4% went into diabetes remission. These patients were on a very low calorie diet of 800 calories a day, so we wouldn't expect that we family physicians would do this, but certainly it does open up the possibility that substantial weight loss is really important for our patients. It has also been shown that many of these patients who sustain the weight loss of greater than 10 kilos sustain the diabetes. So I think we should share with our patients that actually losing weight is really important. And I think when we see it in the Sun newspaper in the UK and the Daily Express newspaper in the UK, we know it must be important if it's making it into the popular press in the UK. That maybe weight loss in the early stages of diabetes might have a really important long-term role. It's too early to say it for sure and for all populations, but it is a really interesting looking down into the future. On one other lifestyle issue, I think it's very important that we would ensure that our patients, and particularly with the coronavirus currently, that we'd ensure that all our patients have the flu vaccine on an annual basis and that they get the pneumococcal vaccine as per guidelines. And again, this would provide both improved patient safety and well-being, but also it's a really valuable and very straightforward audit for us clinicians and a quality improvement project that can be readily undertaken. Just coming back to physical activity and type 2 diabetes, and what I say to my patients is this is for everybody. This isn't solely for people with type 2 diabetes. We should all be striving for this, and it is difficult. 30 minutes of moderate exercise most days, and that's which gets your heart rate up to, So where you're just about to start lightly sweating, like a brisk walk. So 30 minutes of moderate exercise most days. So aiming for a minimum of 150 minutes a week. And this need, like most of us, if we say we couldn't possibly take half an hour out of our busy day to go and do exercise, but actually a short 10-minute block of exercise, like a walk for 5 minutes down the street, 5 minutes back, is 10 minutes exercise. Everyday housework counts, climbing stairs counts, sports count. So I encourage my patients to do what they like best, what they'll enjoy, and what's sustainable. In an ideal world, they would do a combination of both aerobic and anaerobic or resistance training. The light resistance training uses different muscles, so we get a different benefit. And as we know with the physical activity, it burns up the sugar. So that's the purpose of getting people to do physical activity. And from a practical point of view, I get my patients who have type 2 diabetes to go and visit a local physiotherapist, and he goes through with them for 1 hour, and usually their spouse as well, because this is exercise for the whole family, goes through with them an exercise program that's suitable for them, where they are at the moment in terms of their fitness level, giving them both aerobic and anaerobic exercises. And because I don't have the detailed skills to do the aerobic and anaerobic advice for patients at different fitness level. And I find it works well, and most of my patients take this up. Next really important issue with our patients in type 2 diabetes is saving eyes. Unfortunately, diabetes is the leading cause of non-traumatic blindness in adults. And it's a huge loss to the individual patient, to their family, and to the wider society when somebody with type 2 diabetes loses their vision. And often this vision loss progresses very gradually, and patients are completely unaware of it until it's very late. And with good quality care and screening of eyes, and it is important that we would actually screen these patients. So mostly sending them to either an optometrist or an ophthalmologist to have their eyes screened to check for diabetic retinopathy. This is absolutely eminently amenable to treatment. So picking it up early can certainly improve outcomes for our patients. The next major complication is diabetic foot disease. And this is probably the most dreaded of all the complications for our patients with diabetes. And it is the leading cause of non-traumatic foot amputation and digit amputation is diabetic foot disease. And all the evidence suggests that we can prevent about 70% of these amputations. It's very traumatic for patients, it's very traumatic for their families, it's a huge impact on their quality of life afterwards. And from the health service, it's a really expensive complication because these patients spend a long time in hospital with deep ulcers, osteomyelitis, and foot amputations. And so that's why we should screen it. And once a year is enough. So if we do a proper assessment of the foot once a year, if it's normal, and there's three components to the screening really. Firstly is simply a visual inspection, looking at the skin to see is there any breakdown in the skin, are there any small ulcers, the toenails, are the toenails cutting into the skin, do they need to be cut? If they're older people who can't reach their toenails because they lack mobility, checking the bones of the feet, are the bones structurally normal or abnormal, checking the shoes, maybe are there thumbtacks, nails, stones within the shoes, are they wearing evenly? So a visual inspection of the feet. Next part is looking at the circulation within the foot, and for that we'll check the foot pulses, mainly the dorsalis pedis and posterior tibialis. These can often be quite difficult to palpate. And I think most of us family physicians will find that we can find them sometimes and other times we can't. Other really valuable ways of checking the circulation in the foot is simply to check the capillary refill time at the great toenail, and it should be less than 2 seconds. And the foot may often be warm but not hot. And the growth of fine hair on the back of the dorsum of the toes is a good sign that the nutrition, the circulation to the skin is good. So it's a visual inspection, circulatory inspection, and then finally the sensory assessment. And there are many different ways of testing this. The 10-gram monofilament pen is probably the most common, and different guidelines suggest how often we should test it. Some say 4 sites. More commonly nowadays, they say 10, which would be along 3 of the toes, along the plantar surface of them. So 3 of the toes, 3 of the metatarsal heads, 2 in the midfoot, and 1 at the heel, being aware that very often people with thick skin over their heel, their sensation won't be great there. So and then one on the dorsum of the foot. Any loss of 10 gram monofilament repeatedly indicates the person may have a neuropathy. Vibration sense using a 128 hertz tuning fork at the tip of the great toe is another really good way of testing the sensation. And some of the evidence suggests that the first thing we notice in a patient developing a neuropathy is the loss of vibration sense at the great toe. So this is a really important aspect. We need to only check it once a year. And again, it's a good possible audit for people to consider. Have we documented a foot examination once a year in our patients with type 2 diabetes? Then just on a slight aside and looking specifically at patient safety in type 2 diabetes and reduced medication-induced harm, and particularly acute kidney injury. And the Canadian guidelines have this very good mnemonic, and they call it the sad man's medicines. And they are the sulfonylureas or diamicron, the ACE inhibitors, the diuretics, the metformin, angiotensin receptor blockers, so it's the ACEs and the ARBs, non-steroidal anti-inflammatory drugs, and the SGLT2s or the gliflozins. These all potentially impair renal function. Our patients have, say, diarrhea and vomiting, particularly in warm climates like the Middle East. It may be worth considering temporarily discontinuing these medicines for a few days to help protect the kidneys. And one of the things I do is I write on my prescriptions when I give patients these medicines that if they're unwell with diarrhea and vomiting, talk to their pharmacist or family physician about temporarily discontinuing these medicines. It's really important that we tell our patients to restart them afterwards. And this is aimed at helping prevent acute kidney injury in our vulnerable patients with type 2 diabetes. As we know, many of these patients have a degree of chronic renal impairment already. So prior to our patients coming in to see us family physicians, what investigations might we like to have done or would we do when we're seeing them? And these are some of them. Obviously, we need the pressure, height, and weight. We'd like their HbA1c. The lipids, as we know, the new American guidelines say that the lipids don't have to be fasting. People can have a light breakfast, as I say to my patients, not the full Irish breakfast, which is a huge feast. We'd like to check their renal function, creatinine, EGFR, and the urine for their ACR, or microalbuminuria creatinine ratio, whichever is available locally. Thyroid function, liver function, because very often our patients with type 2 diabetes have a lot of fat deposit in the liver causing non-alcoholic fatty liver disease. In Ireland, we certainly have a high rate of hemochromatosis, so we would usually check people for ferritin as a comorbidity, and a 12-lead ECG for two reasons. Firstly, to establish a baseline ECG to compare it to future ECGs, but also many of our patients have silent ischemia as part of their diabetes. So coming now to look at the pharmacological management of our patients with type 2 diabetes. And I've said here a statin for inverted commas everyone. Now, it's not quite everyone. If we have women who are planning a pregnancy or actually pregnant, clearly we wouldn't be giving a statin in that situation. And possibly in people under the age of 40 without any evidence of cardiovascular disease. But outside of those limited numbers, it's probably worth giving serious consideration to putting or offering most patients with type 2 diabetes a medication, a statin. And again, I try to keep it very simple and so that family physicians don't have a whole plethora of targets to try and remember. The Australian guideline essentially says that everyone with type 2 diabetes, we should aim for an LDL of less than 2. And that's a very easy figure for our patients to comprehend. So I think that's a reasonable target for everybody. More detailed guidelines would suggest that an LDL is the target. That's what we're really looking at. Less than 2.5 if they've no overt cardiovascular disease, less than 1.8 if they've overt cardiovascular disease such as angina, peripheral vascular disease, maybe a prior MI or a stroke or atrial fibrillation. But that's not hugely dissimilar to less than 2. Some of our patients, as we know, may have an LDL of 4.55 or even higher. And even with high dose statins, it may not be feasible to get it down to less than 2. So a greater than 50% reduction in LDL, 40 to 50% from their baseline LDL is an acceptable target also. And very often that's what we will aim for, is we may bring it down from an LDL of 5.5 to 2.1. And again, in my fictitious patient, if I got that, I would say, well, that's a reasonable target for this patient. And again, maybe think of doing an audit of the LDL values among your patients, looking where are we in that. And most of us family physicians will find that getting the lipids right is not a major difficulty. It's generally straightforward. We just increase the statin until we achieve our target, assuming the patient is taking it. So it's not difficult, and most of us will find this is one of the easier targets to achieve. Just looking at more to dismiss it than anything else, the role of aspirin in type 2 diabetes, and there was a vogue a good number of years ago, the concern about type 2 diabetes and cardiovascular disease and silent cardiovascular disease for putting most patients on aspirin. And at one stage, I did have most of my patients on aspirin with type 2. And then evidence came out suggesting that it wasn't beneficial, so we became much more selective on it. And the current guidance is that really if there's no evidence of cardiovascular disease, then that aspirin isn't indicated. And if there is evidence, then aspirin is secondary prevention as per normal cardiovascular prevention, and we should offer aspirin. But in terms of for type 2 diabetes, it shouldn't be an automatic anymore. Then the next thing to address with our patients, and this is a really important driver of illness and morbidity and mortality in people with type 2 diabetes, are the management of hypertension and high blood pressure. And we know that hypertension drives the microvascular and macrovascular complications. While I said that the statins and cholesterol and LDL are relatively easy to control, I think we'll all agree that getting someone's blood pressure to target is much more challenging. The guidance is that we would measure the blood pressure at each visit. And checking for postural hypertension is especially important for people with type 2 diabetes, because people with type 2 diabetes get, as we know, they can get a diabetic autonomic neuropathy, which can affect the heart and the peripheral vessels. And these patients can have a seemingly normal blood pressure, but when they stand up, their blood pressure drops and they can become symptomatic. So it's always worth asking them if they're getting symptoms of it when they stand or get out of bed in the morning, particularly for older patients. And the current guidance is we can check it when patients are either lying or sitting, and then they go to standing. We check, is there a drop in blood pressure and a reflex of tachycardia. So it is worth checking it. Home blood pressure monitoring is increasingly used. And finally, the office blood pressures are unreliable. So in addressing blood pressure for our patients, we've already, with the statins, addressed the role of a dietitian, but the role of lifestyle changes in blood pressure management are equally important, and that we should encourage our patients to reduce salt and salty foods, alcohol if appropriate. We should encourage our patients to undertake exercise, because exercise reduces blood pressure, and weight loss has an important role in helping reduce blood pressure. And it's important that we would personalize and agree the target with our patients, because some people with very high blood pressure, bringing it down to at all is very helpful. And equally with frail elderly patients, maybe with terminal care, sticking rigorously to guidelines may not be in their best interest. So it's important to personalize it and agree it with the patients. The European guidelines have become very clear, and I try and pick guidelines that are very clear so that it makes it straightforward for us family physicians. And the target blood pressure is what is for simply 120 to 39 over 70 to 79. And you know, we could consider an audit of this. And the guidelines suggest that for systolic, that we treat it if it's greater than or above 140, and we should avoid a systolic of less than 120. So the practical impact of this means that if my patients are on blood pressure medication and I find it's above 140, I intensify the treatment. Equally, if their systolic is less than 120, I recognize that they're likely to suffer symptoms of hypotension, and there is no benefit to them. There's no additional therapeutic benefit to being on it. So if their systolic is less than 120 repeatedly, when I check it a few times, then I will actually, if possible, de-escalate or de-intensify their antihypertensive medication. Within the age groups, the guidelines suggest that we can accept an higher level for olds. We all know it's more difficult to get it down, and they're more susceptible to the effects of low blood pressure, of 130 to 139. And for younger people under 65, target to 130, but down as low as 120 if they tolerate it. So I think these are reasonably easy targets for us, at least to remember and aim for. And the diastolic is 70 to 79, avoid it less than 70, and they don't recommend treating it unless it's above about 90, but the guidelines for that are a little bit more variable. European guidelines again said that, and this comes back to the therapeutic inertia, and what it's known is that about 2/3 of patients who take two medicines, a two-drug combination, will be controlled, and about 3/4 of patients will be controlled with using 3 or more drugs. So historically, we would have started with a single drug, titrated it up, then added in a second one. And this could take maybe 6, 12, 18 months or longer. So the current guideline is that treatment should usually, not always, but usually be initiated with a 2-drug combination of an ACE or an ARB with a calcium channel blocker and a thiazide. And I suppose we would use whatever we're familiar with. In my personal patient population, a lot of my patients are middle-aged and older men, and I find if I give them a thiazide that they come back 3 or 6 months later and they've got gout. So increasingly I lean towards using a calcium channel blocker, but this is what the guidelines say. All the pharmacotherapy agents are very effective. They're highly effective. They protect the kidneys. They reduce cardiovascular morbidity and mortality. In terms of patient safety, and so if I have my fictitious patient, I'll need to check the UNEs about 1 to 2 weeks after initiation or intensification of an ACE or an ARB. And we all know that we shouldn't use the ACE or the ARB together. A combination of them is contraindicated. They're really adverse renal adverse effects. So the 2 take-home messages from treatment hypertension in type 2 diabetes is the target is 120 to 139 over 70 to 79, and treatment should usually, but not always, be initiated with drug combination, 2-drug combination, and consider an audit. And now, so we've looked at lots of the other stuff around type 2 diabetes, and so I hope you'll have come to the realization that actually the glucose lowering, while it's part of it, there are also very other areas in the management of type 2 diabetes that are equally important. Again, just to reiterate, with glucose lowering and getting the HbA1c down, we should avoid therapeutic inertia. So if after 3 to 6 months we're not seeing an improvement, we should assess compliance and intensify the medication. We should always look at the lifestyle measures, weight loss, and exercise. And again, as with the blood pressure and the lipids, we should personalize the HbA1c, that it's agreed with a particular patient and centered on what their needs are. Ideally, it would be less than 53, but you know, it's certainly acceptable to have it higher in some people, particularly in people in the end of stage life. And these are the ADA EASD consensus statement. So the ADA EASD is very extensive. It's a fantastic document, but it's nearly 40 pages long. So we're just going to go through it in what I find is a very easy synopsis of it. And what we know are there are 8 different classes of hypoglycemic medicines, 28 dual combinations, 56 triple combinations. So it's really quite a complicated field. And what I hope to share with you in the next few minutes is a safe, easy manner of initiating and intensifying medication to lower glucose for all our patients. And very simply, it's metformin for virtually everyone. Metformin is very safe, it's low cost, effective, it's cheap, and crucially, it doesn't cause hypoglycemia. So it's essentially metformin for everyone. It does have side effects, particularly gastrointestinal side effects. So ideally, we'd start maybe at 500 micrograms once a day. If patients complain of side effects with that, this is such a fantastic medicine that I would encourage them to split the tablet and maybe just take half a tablet, just 250 milligrams once a day, and they will develop tolerance to the side effects usually within a week or two. The maximum effective dose of metformin is 1 gram twice a day. Sometimes we may have patients on 850 3 times a day or even more, but there is no evidence that exceeding 1 gram twice a day gives any more effect. So it's worth considering an audit of your dose of metformin for your patients. Then the ADA ESD guideline, and again, I have taken a very easy synopsis. What they do with this is they stratify our patients into 3 groups: those with established atherosclerotic cardiovascular disease, which would be things like an MI, angina, TIA, previous stroke. So people with cardiovascular disease, people with chronic kidney disease or heart failure. We know about 20% of patients with type 2 diabetes have heart failure, many of it undiagnosed, and everybody else. And these are the majority. So there's 3 groups of patients. And if you look at the guidelines, the ADA ESD guidelines in detail, they go through each one of these in exhaustive detail. But there is, if we look carefully at it, there is an easy pathway through this. And so we said metformin for everyone. They grouped the 3 people into cardiovascular disease, heart failure, chronic kidney disease, and the majority. So the guidelines suggest that for the first step is metformin, and I'll deal with these in a little bit more detail next slide. SGLT2 or GLP-1, and the third line is the alternatives. So these are 3 different steps that we can use. And this combination, these are 3 steps. We can have patients on 3 different medicines. They're very safe. They're effective in all these categories. They're effective in, and they're safe and effective in people with cardiovascular disease, with chronic kidney disease, with heart failure, and with everybody else. And crucially for us and for our patients, they don't cause hypos. So looking at them in a little bit more detail, this first line is metformin, and the EA is the SGLT2s, or the gliflozins, as I like to think of them. And these are very safe and effective, provided the eGFR is over 60. These are dapagliflozin, cana, empagliflozin, and some of the newer ones. And these are tablets, and they simply improve, they cause patients to excrete glucose in their urine. So the key finding with this is that they're safe and effective in people with heart failure because they remove fluid from the body. They're safe and effective in people with kidney disease. But we need to be careful as the eGFR falls. So they're fine once the eGFR is over 60. Once the eGFR goes below 60, you need to check the SMPC to check which ones are safer at what eGFR. But they're very safe and they're very effective. The alternative to this is the GLP-1 receptor antagonists, and we are fortunate we have these, and these are given by injection. Dulaglutide and exenatide are weekly, and some of them are daily. But I do appreciate that these aren't available to maybe family physicians in Saudi. So I'll come back to that in a few slides' time, what alternatives we might consider where the GLP-1s aren't available. But for us family physicians, the gliflozins are tablets we're used to prescribing them. They're very safe. They're safe in patients with heart failure. They're safe in patients with chronic kidney disease. They're safe in patients with atherosclerotic disease. So they're a really good second line consensus recommendation. So the gliptins are an alternative if we can't use the other ones. So, and what I used to use prior to the dulaglutide and liraglutide, I used to use one of the DPP-4 inhibitors, and these often come in combination with metformin. And they are safe, they're effective. However, they are among the lesser effective medicines in reducing HbA1c. They are neutral on patients' weight, and they're very well tolerated. So they are safe and effective, but they're not as effective as some of the alternatives. Just to mention about gliclazide or diamicron, I think increasingly you'll find this has fallen out of favor. And if you look at the ADA ESD guidelines, really it's well down the list of priorities. And this is for several reasons. Firstly, it it works on the remaining beta cells to try and stimulate insulin production. But as we know, these beta cells get worn out. It causes hypoglycemia, particularly in the elderly. And I know several years ago in my local emergency department, they told me they had about 2 older patients per month coming in with a glucose of less than 2 while taking diamicron or gliclazide. The gliclazide isn't particularly effective when patients are on it for a longer duration of 18 months or more, because the effectiveness of gliclazide wanes with time and they cause weight gain. So there's lots of reasons not to use it. It might be worth considering an audit of your patients on gliclazide, particularly if they've been on it for a considerable number of years, to see is it worth continuing it. However, it is very effective and it is low cost and maybe worth considering in the early stages of type 2 diabetes. And the third line, according to the ADA ESD, remember, first line is metformin, second line is an SGLT2 or GLP-1, the injections, and third line is the alternative. But we do understand that the DPP-4 inhibitors may be a reasonable alternative. So just looking at that again, looking at the first line, second line, third line. So if we are putting patients on 3 medicines for glucose lowering, we're really doing very well. And as we said, we haven't mentioned insulin at all, because that's a completely different medicine, and the management of that really is quite specialized. Just some safety things to consider. We've already said that for many of these medicines, provided the eGFR is 60 or above, they're fine. With metformin, we should, again, keep an eye on the eGFR, reduce the dose if it's under 45 and stop it if the eGFR is less than 30. So just always keep an eye on the eGFR. And again, once the eGFR goes below 60, we need to check and see, are the medicines our patients are taking safe to continue taking? And then we also need to look at other potentially nephrotoxic medicines like non-steroidal anti-inflammatories, which patients may be taking themselves, and make sure that we don't inadvertently cause acute kidney injury, and that gliclazide diamicron causes hypos and isn't long-term effective. Avoid pioglitazone and saxagliptin and heart failure. It's my preference to try and avoid medicines that cause problems. So pioglitazone and saxagliptin have a tendency to cause heart failure or exacerbate heart failure. And we know that 20% of people with diabetes probably have undiagnosed heart failure. So, you know, it's generally worth avoiding problem medicines. So just to conclude that, 3 groups of people: cardiovascular disease, chronic kidney disease, heart failure, and the majority. And the guidelines say that self-monitoring doesn't actually improve glucose control. So, you know, unless we have a clear reason for it, obviously it's really important for people with type 1 diabetes or gestational diabetes to check their blood sugars, or if someone is taking medicines that actually cause hypos. But it's not indicated for most people, only if they're on insulin or medicines like gliclazide, or if glycemia would cause a major problem, like if they're operating machinery. But for most people, it isn't indicated. So the ADA ESD consensus, 3 groups of patients, and a very simple way of doing it really: metformin followed by etliflozin, and then perhaps either injection or a DPP-4. This is safe. It's safe in all those categories, and it's very effective and doesn't cause hypos. So just to conclude, so we've case finding we should be looking at perhaps everyone aged 40 to 45 years, everyone aged in that age group, and not our high risks. Weight loss for everybody. More actually is more. Ideally lose and sustain between 5 and 10% or possibly more. The target blood pressure is 120, 139, diastolic 70 to 79, dual combination therapy, glucose lowering, metformin, followed by the gliflozins in an injection or a DPP-4. So I hope you found that helpful. It's been my pleasure to communicate with you, and thank you for giving me the honor of participating, and I look forward to working with you in the future.
Thank you very much, Dr. Quinlan, for the excellent presentation, very practical and simple approach to a very common disease. Thank you very much for simplifying this extremely important topic. Before we take a few questions, I want just to emphasize on the need for case finding or screening in especially in our society, because of the high prevalence of diabetes. So the yield will be even higher on what you will see in Ireland or UK or any other countries. And I would add that, you know, there is a debate when to start in Saudi Arabia. Should we follow the, you know, recommendation which is adopted by most authorities in the world, like, you know, the Canadian, the Australian, the American, around 40 to 45, or we should go lower? One suggestion is actually to go lower. And I believe personally that maybe 30 is a good timing, or even before that, if the patient present or have risk factors. There is a very important study that was published by Dr. Bayan. He's one of the, you know, leaders when it comes to diabetes and diabetes research in our country, Saudi Arabia, very well known researcher and endocrinologist. And in that paper, he analyzed actually the administrative data of 50,000 of the Saudi population, and he concluded that around 12% of the Saudis by the age of 18, 20, they are either diabetic or pre-diabetic, which is, wow, you know, very high. That's why I would go lower personally. I would recommend lower, going lower. Unfortunately, we don't have an authority, you know, in Saudi Arabia who can recommend. The Saudi CDC, which was established recently, they recommend, they took the figure of 45. I think they just adopted it from other international bodies. I think personally we should probably go a bit lower based on the data from Dr. Bayan. I like also your emphasis on weight reduction and lifestyle modification, extremely important. And as you mentioned, research is supporting this, because what I see, you know, from some of our trainee and sometimes even trainers, they jump to metformin, which is fine. It's an option, but we should. It's the easy option actually. You know, working on the diet, on the exercise, which can affect different, you know, parameter of the health of the individual is extremely important. And we have actually data and research, randomized control trial comparing lifestyle modification with a reduction, as you mentioned, just 5%, which is not that difficult, compared to metformin. The benefit is higher in terms of the prevention of diabetes for lifestyle modification. In addition, in that trial, actually, there was a significant increment in nephropathy, renal, you know, impairment after 10 years of the use of metformin. So metformin is a great drug, but it's also not necessarily the first line, you know, especially in our community. Otherwise, I remember Dr. Bayan again. I caught his you know, answer when I asked him this question actually one day, and he told me, if we have this way of thinking, we need to put metformin in the tap water, and I would agree with him. So we need to focus on lifestyle modification and minimal reduction, 5% of the weight. Thank you very much again. Now we will open the floor for the discussion. Any question, please, from the audience? I guess you can raise your hand. Or
I think Dr. Nada has a question there. Is she unmuted? She wanted to ask a question. I just see a message from her there. Can you unmute it, Ian? Or?
Yeah, bear with me for 1 sec. Just the list. And she is unmuted.
Yes, go ahead.
Hi, doctor. Hi, doctors. I don't know if you are hearing me. I'm at the airport. But
yes, we can hear you.
Thank you very much for the presentation. It's really practical. I'm thinking of the other sulfonylureas medication. would we consider it as a second line or third line? What do you think?
Sulfonylureas other than gliclazide?
Dimicron. Yeah,
Dimicron.
Yes.
Perhaps I might defer to Professor Abdullah, because the only sulfonylurea that we have available in Ireland is actually diamicron. So I have no experience in the other sulfonylureas. And I have found that because of the side effects and the fact that the other medicines, particularly the gliflozins, are they're very safe. They don't cause hypos. They're safe in cardiovascular disease and kidney disease and heart failure. That actually they have become either second or third line. And the use of diamicron is vastly less, and the sulfonylureas is the only people I have them on now are those where it's probably fourth line and has been recommenced by my hospital endocrinology colleagues, more because they've run out of alternatives and the patient doesn't want to go on insulin. But perhaps Professor Abdullah might have more experience in the use of alternative sulfonylureas.
I agree with you. We have other alternatives. So the most commonly used probably is the glibenclamide, however, there are few concerns that was raised about glibenclamide, especially in the elderly, increment in cardiovascular, outcomes, increment in renal disease, and that's why, at least in the hospital where I work actually, we used to have glibenclamide. It was withdrawn actually from our formulary because of these concerns. I think it's still available in other sectors. And I would say that dimicron is probably a better choice when you compare it to glibenclamide.
Yeah. Thank you.
Thank you, Nada.
Thank you, Nada. Any other question?
Can I just come in to reiterate what Professor Abdullah said? And when I have somebody with either pre-diabetes or newly diagnosed type 2 diabetes, and it's about the relative role of weight loss, exercise, and metformin, I get out a sheet of paper and across the top of it I draw sort of pre-diabetes, impaired fasting glucose, impaired glucose tolerance, and type 2 diabetes. And I draw them across the top and I say, look, you can go between one and the others. That is, your diabetes can go into remission. And then explain in great length about the weight loss and the exercise and what they do. And literally in the bottom corner of the page in small print, I put metformin to highlight that actually weight loss and exercise are the key issues that are sustain long-term glycemic change, and that metformin, while it's important, has a weight loss and exercise, as Professor Abdullah said, are the key changes that patients can make themselves.
Excellent approach. Thank you very much. Any question from the audience?
Yes, please. I have one question.
Go ahead.
I don't know if, yeah. Thank you, Professor, for this lecture. And I have a questions regarding one point you mentioned about if we have high-risk patients for renal disease, we may stop temporarily some of the medication that might cause renal problem. I didn't get this point, like when to do it and for how long we can stop the medication, then restart it again.
Thank you, Zainab. Are you asking me or Professor Abdullah?
Yes.
No, this
yes.
is for you.
Okay,
Thank you. It's an important issue, but it's only a minor issue. But what I would suggest is that if patients on the potentially nephrotoxic medicines, like the SADMANS group of medicines that we mentioned, if they develop, a reasonable amount of vomiting or diarrhea and are unwell with it, so they're not taking fluids, particularly in a hot climate where they may be sweating and becoming dehydrated, they are prone to acute kidney injury. So I simply tell my patients, firstly, they should either contact their doctor or their pharmacist and stop them for a few days and restart them when they're eating and drinking normally. they won't come to any harm by stopping their antihypertensives for a few days. And when they're sick like that, their blood pressure will drop anyway, particularly if they're dehydrated. So it's simply a rule of thumb: stop it for a few days. Start it when they are eating and drinking as normal. Does that make sense, Zainab?
Yes, thank you.
Thank
Thank you, Dr. Quinlan. And again, some of these advices you might not hear it from the cardiologist or endocrinologist, because our management of diseases as family physician is a bit different from the approach of the specialist. We have an open and access between us and the patient, so it's okay to modify a certain medication for a few days, because we are accessible. We're not like the specialists where it's very difficult to get into contact with them and communicate with them. Thank you very much. Any other question?
Yes, I have one question.
Go ahead.
Regarding our community, we have a lot of patients who have sickle cell disease, and they are known case of sickle cell disease. How I can judge accordingly to hemoglobin A1C, whether this patient, especially the patient newly diagnosed with a borderline just 7 A1C, hemoglobin A1C will be 7, or whether this patient controlled or not? If they are sickle cell disease, any point that I can judge this is it's high because of their nature of the disease, or they are really uncontrolled?
May I please? I have no one in my population ever with sickle cell disease, and I'm sure Professor Abdullah can answer that question very comprehensively for you.
Yeah, hemoglobin A1C can be affected by the presence of sickle cell disease. It can give you some idea, but again, it's not accurate. Another way of monitoring diabetes in such a population is monitoring home blood sugar readings and reading it more than depending solely on the hemoglobin A1C.
So for this special population will depend on home readings blood sugar more than A1C.
Yes, although hemoglobin A1C will give you some idea, but it's not accurate. There are, yes, as you mentioned, the result can be affected.
Okay, thank you.
Okay, any other question?
Yes, I have a question.
Go ahead.
For uncomplicated diabetes, should we reach to the minimal effective dose 1,500, or we can keep the patient, for example, on 500, then we act according to hemoglobin A1C?
Is that to me, Dr. Rehab?
Yes.
Yeah. Can I just check I got the question? We're talking about metformin.
Metformin, yes.
Yeah. So when I diagnose it, again, if you take my patient, like when I first, and I would be looking at, and I would agree with Professor Abdullah, I would think you could start testing your patients at a younger age, particularly if you find if you test them at 40 or 45, you're diagnosing a lot of type 2 diabetes. But once we find our patients with pre-diabetes, that is, the ADA consider it HbA1c of 39 to 47. The European societies pick it at 43 to 47. So I would do the weight loss and exercise piece with them. And then I would start them, if they're at 48 and they're climbing, certainly going towards 53, I would consider starting low dose metformin, either 250 just to get them used to it, or 500. And that's often enough, and may keep them like that for a year or 2 or 3. If, however, it's not enough, or their HbA1c is climbing, then I would gradually increase it. I'd go from 500 once a day to maybe 500 twice a day. If that was enough, I might change it back to 1 gram once a day just to reduce their tablet burden. And I would gradually increase it up to 1 gram twice a day over the time frame that's necessary to keep it ideally under 53. Does that answer your question, Dr. Rehab?
I mean, is 500 work in diabetes?
Yes.
Or we should,
yes.
Because I read in some resources, we must reach to 1,500.
Yeah, so 500, it depends how high you're starting at. So if you pick people up at an early stage where their HbA1c is, is somewhere between 48 and 53, 500 milligrams will often keep them at that level for several or many years, especially if you do weight loss. But diabetes, as we know, is a progressive disease, type 2 diabetes, because we lose our beta islet cell production of insulin. So over the passage of a number of years, they are likely to need a higher dose of metformin, up to 1 gram twice a day. So 2 grams a day is the maximum effective dose. So most people will need that ultimately at some stage.
So you don't need to start patient right away with the highest
No.
dose. You adjust the dose. You can start with 500, then you go slowly and increase the dose. Thank you very much.
Safe. It's very safe. It's effective. It doesn't cause hypos. It's a fantastic medicine.
Absolutely.
Okay, thank you.
Cheap and fantastic.
Yes.
Great combination. Okay. Any other question?
Tony here. There's a question there in the chat box there. Somebody's asking you to repeat what the advice about aspirin is for the type 2 diabetic patient. Yeah. When would you start it?
The long answer is that a good number of years ago, it used to be aspirin for everybody because of the concern about people with diabetes having an excess of cardiovascular mortality and morbidity. But then evidence research showed that actually there isn't a benefit. So essentially, I took all my patients off aspirin unless they were on it for secondary cardiovascular prevention. So if you have a patient with type 2 diabetes who doesn't have, if they have angina or a previous MI or a stent or maybe a previous, maybe carotid stenosis, then they may well be on aspirin for that reason, but it's that reason rather than the diabetes.
The issue of aspirin and diabetes is getting complicated, as you all know, because of the recent trial, especially in 2018. Multiple trials were published, were negative. So I agree with Dr. Quinlan. Right now, the general recommendation of using aspirin for the primary prevention of cardiovascular disease is probably going out of fashion. This is the general principle. But I mean, this is another topic. I gave recently a full presentation about this, reviewing the 15 different trials, especially the last 3-4 trials that was published in 2018, which really flipped the recommendation, the ASPIRE and other trials. So in general, the general recommendation at this current era, aspirin for primary prevention of cardiovascular disease is probably not recommended.
Yeah, absolutely in agreement.
Any other question?
I don't want to interrupt, but there's one there in the chat box again, just asking about diabetes, a diabetes patient with high blood pressure, and the advice about starting with 2 antihypertensive medications. Diarmuid, is that what the guideline is saying, that you should,
that's the European guideline, and it is for most patients. So not an absolute recommendation, but for most patients that they would take a dual combination product, and the reason for that is that historically we used to start with a single agent and titrate it up, and then add in a second and titrate it up. So patients could have high blood pressure, uncontrolled high blood pressure for often several years. With starting a dual combination, in most people, we can get the blood pressure controlled in about 2/3 of people from the outset, and it comes back to the therapeutic inertia, avoiding therapeutic inertia. So a dual combination product for most people is recommended, and that's the reason why.
Thank you. Any other question? Any other question from our trainee?
Dr. Abdullah, I think there is in the chat box, there is a question was written during the presentation. Can we check them?
Okay.
It's one for you, Abdullah. It's about sickle cell disease.
We have started.
I think you should answer that one, Abdullah.
Which
I'll plead ignorance.
What it says is HbA1c. Is it accountable if the SCD patient was on hydroxyurea or doesn't have crisis?
I think we answered this. You know, with hemoglobin A1c among the sickler, it's not as validated as you know, patient without. It doesn't mean that you cannot believe in them. You can utilize them, but you need the support of the blood glucose monitoring.
Yeah.
I think we answered, even the one in the chat, we answered most of these questions. Yeah. Any other question? If there aren't, we will close, you know, now.
Yeah, okay.
It's already. Okay, so thank you very much, Dr. Quinlan. It was an excellent presentation, very well, you know, simplified, practical presentation. So thank you very much. And really great attendance from our trainers and trainee. Thank you very much also for your attendance, despite the fact that it's after hours. This, you know, gives a clear idea about the dedication of our, you know, young coming generation. So thank you very much, all.
Thank you for inviting me. I'm honored to participate.
Thanks very much. Yeah.
Thank you, Diarmuid. You've been fantastic. Well done.
Thank you. Well done. Bye.
Bye. Bye.
Bye.